Just a moment. Just a moment, ma'am, please.
Please go live. Let's start.
Yes, ma'am. Just going live. Just a moment, please. Yes, ma'am. You are live. You can start, please.
Okay. So, good morning, everyone. We welcome you to yet another session of ISMSICS, and we begin this year with the installation of the Young Ophthalmologist chapter of ISMSICS. So today on the 2nd of January 2022, we will install this chapter. So welcome once again, and before we embark on the installation ceremony, let me first introduce you to the ISMSICS team. We have with us Dr. Amulya Sahu sir, who is the founder chairman of the society, Dr. Boramani sir, who is the executive chairman of ISMSICS, Dr. Parikshit Gogate sir, who is the vice chairman of the society. We have with us Dr. Satangshu Mathur sir, who is the chief national coordinator. And we have with us Dr. Debashish Bhattacharya sir, who is the president of ISMSICS, Dr. Srinivas Joshi, the secretary of the society, and we have Dr. R.T. Heda, who is the national and international coordinator of the society. We welcome you all to this installation ceremony. And before we begin, may I please invite Dr. Amulya Sahu sir to give his opening remark. Sir? So you are on mute.
Thank you, Nilutpanda, for this nice introduction. And it is my pleasure to welcome the young brigade to our fold. And I thank Aarti for starting the process of bringing this young energy into ISMSICS and Nilutpanda for taking it forward. So as you know that our focus is the next generation. And we want what we have dreamed of, that SICS is one of the artistic surgery that the world is now waking up, and tomorrow they will be all lapping it up. And we have brought to a level where we can stand vis-a-vis PECO and tell with confidence that we do excellent surgery and the result is there to show. So now I have started breaking the necks in the bag. And so nothing is left now. And Nilutpanda, whom I just had the privilege of teaching this 2 millimeter, has taking it forward into a next level. So he is putting a PMMA lens in a 2 millimeter incision. So that the world is here to see what kind of magic we can do with SICS. And I want this young brigade to focus and take pride in what the gift of SICS we are making to the world. With this word, I thank you all and welcome to this ISMS forum. Thank you.
Thank you so much, sir, for your encouragement and always inspiring us to move forward towards teaching and training SICS and also learning from the most eminent personalities of ophthalmology. May I now request Dr. Jagannath Boramani, sir, who is the executive chairman of this committee, to kindly share his talk.
Yeah, good morning, all of you. Can you stop sharing? I have to share the screen. Can you see my screen?
Yes, sir, it's visible.
Yeah, and I'm audible, no?
We can see it, sir, and we can hear you.
Yes, sir.
Yes, yes. So, good morning, all of you. Today is a very important event because this is the only chapter of ISMSICS, or the only wing of the ISMSICS, which will be perhaps most active. Being the youngsters, it will be most active chapter, and I think all of you have to do a lot of work for ISMSICS. So I welcome and congratulate Dr. Bhatia, Karan Bhatia, Nandini, Dr. Raki, and the entire team, the coordinators, for coordinating the event and the installation of the youth wing, the Young Ophthalmologist chapter of ISMSICS. My talk is briefly for the audience, those who don't know about the ISMSICS, brief journey of ISMSICS. ISM SICS is the International Society of Manual Small Incision and Cataract Surgeons. It is perhaps the only global ophthalmic society which has base in India. This was found long back in 2005 by Dr. Amulya Sahu, that this was basically his concept. And in an event in Mumbai in 2005, we installed this International Society of Manual Small Incision and Cataract Surgeons. Immediately after the installation, the same year, our team went to China for an international event. Followed by that in 2007, there was a 3 days SICS workshop organized by Tun Hussein On National Eye Hospital in Malaysia. This was followed in the next year by 2 sessions given for ISM SICS in the Indonesian annual conference. The whole conference was conducted under the aegis of ISM SICS. Next year again, in the same year, the team went to Egypt also, Sweden also, and in the next year, there are 2 sessions given again for ISM SICS. In 2013, we conducted live surgeries workshop and seminar in South Africa. Then in 2005, ISM SICS was invited to conduct wet lab in APSARS conference in Malaysia. I was the first editor of ISM SICS and we have published almost 6 journals. Now the journal is being relaunched under the leadership of Dr. Varun Nayak and Dr. Purvi Bhagat, and all of you are invited to contribute to the journal. The link can be provided by us, and the first issue will be out very soon, but still 1 or 2 articles more are required. Then from 2015 onwards, we started holding world conferences. Our world conference is called as CCC, the Comprehensive Cataract Conference. The first conference was held in Pune, which was a 3 days event. This was followed again for the next world conference. Arvind Eye Care System partnered with us, and we conducted it in Chennai. Again, it was a 3 days grand conference. In the same conference, ISM SICS entered into memorandum of understanding with Help Me See organization. This organization is into teaching SICS through the virtual simulators. In World Conference in Barcelona, 2018, again, we conducted a session, and as a satellite event, there was a wet lab organized by Barekar Eye Institute, and we conducted a wet lab also. And Professor Rafael Barekar launched our e-book, the Master's Guideline of SICS, in this conference. There were multiple conferences across India. We partnered with so many CMEs, and ISMSS was given platform in various state and national conferences. The 3rd World Conference was again a big event in 2019 in Kolkata, aptly conducted by Dr. Debashish Bhattacharya and his team of Disha Eye Institutes. The All India Conference of AIOC also is giving continuously 2 major sessions, the Magic of SICS 1 and Magic of SICS 2. For last 4 to 5 years, they are giving the sessions. And this session is always kept in Hall A, the biggest hall in the conference. AIOS also gave us platform in the WOC, the last WOC, which was a virtual one. And 1 session of AIOS was conducted totally as an SICS session, and the speakers were all ISMSS speakers. Our next conference is coming soon. The dates are changed. It was in September 2021, but it was postponed to February. But now the dates are finalized in March. The dates are the first Friday, Saturday, and Sunday of March 2022. And our announcement will be very soon out on the website. Already we have got more than 400 registrations. Professor Bonnie Henderson announced our next conference in US, but this will be converted as a 6th conference in US. And our 5th will be partnered with L.V. Prasad Eye Institutes. We have presence now on almost all the states of India and almost 20 countries outside India. This is the Help Me See simulation training program, which has been started with partnership with ISM SICS. We're also starting the Global SICS training program, which is a web-based teaching program. And this program can be, all the ISM SICS member will have free access to this SICS teaching program through the web. We did a lot of launching of various international chapters through webinars. We did almost more than 40 webinars now during the pandemic, and the maximum attendance almost touched 10,000. Recently, we launched the Women's Wing also ISM SICS. These are the snaps, the glimpses of the physical launching outside India. One was in Egypt and one was in Bangladesh. So I request everyone in the audience, those who are not member, to become member of ISM SICS. You can take the membership online on our website, which is www.ismsics.com. Thank you very much.
Thank you, sir. And that was really an inspiration to all the young ophthalmologists who will be joining today and who have already joined in, so that they can take the membership up for ISMSAS. So moving on, may I request Dr. Parikshit Gogate sir to kindly share a few words.
Good morning. Thank you, Dr. Linus Parana. It's good to have the young and dynamic YOC teams being a part of ISMSICS. And as Dr. Sahu and Dr. Boramani said, we greatly look forward to the young ophthalmologist contribution for SICS fraternity, because they are the ones who will carry this torch forward. And in many ways, SICS is India's unique contribution to global ophthalmology. And just last month, we got to see that in terms of the research publication, Indian ophthalmology is now ranked third after the US and Chinese ophthalmology. So thank you again to Dr. Aarti, Dr. Dipanjan, Dr. Nilusparna, and all the team, and Dr. Satanshu and Dr. Deepak for putting this all together. And I'm sure we will all do a lot of new and good things together.
Thank you, sir. Thank you. We look forward to work under your guidance, sir, and take this forward. May I now request Dr. Satanshu Mathur, sir, to kindly share his words of wisdom.
Thank you, Dr. Nehru. First
Yes.
of all, I would like to congratulate our young brigade led by Karan Bhatia and others. And thank you, Aarti, and you, Nirupama, for bringing it on the platform. We wish them good luck. We are there to guide them, to help them whenever they need. But we wish Karan and others to make all the young generation aware of this technique, and they should know, or you should tell us how they can learn it and how can we help them. Only then mentor can help them. So you have to talk to the young generation, you have to organize the meetings of the young generation, and you have to teach them about the SICS. And we know Dr. Sahu sir and Dr. Boramani vision is to give this platform to new generation, to new people, and that's why this has come into the existence now. So we wish you good luck and Happy New Year to all of you. Thank you very much.
Thank you. Thank you so much, sir. And I would like to convey Dr. Debashish Bhattacharya sir's message to all of you that he wishes us good luck and he wants to see young ophthalmologists do more of SICS, and also looks forward to the leadership of the team of MSICS to guide the youngsters. Unfortunately, he's down with COVID, and we wish him all good health, and we hope that this new year brings him more prosperity. Dr. Srinivas Joshi sir also sends his warm wishes, and he gives an announcement that he looks forward to the Yo Pavilion at the upcoming World Conference of ISMSICS that is going to be held at Chandigarh. And we thank him for his sincere efforts in bringing the young ophthalmologists to the ISMSICS Pavilion. We have with us Dr. Aarti, and we are very thankful to her for her initiative. Dr. Aarti, you want to say?
Dr. Nilusparna, I thank all the seniors for this great initiative and a wonderful opportunity to all the young ophthalmologists, including me. And I welcome you all to this family of ISMSICS, and we have a very long journey together, and I'm sure this is going to be an exciting journey. So all the best.
Thank you. Thank you so much, Dr. Aarti. And with that, we move on to the installation of this meeting. So first and foremost, we have the members of the ISMSICS Advisory Committee, Dr. Amulya Sahu sir, Dr. Jagannath Boramani sir, Dr. MS Ravindra sir, Dr. Harsha Bhattacharya sir, Professor Manisha Rathi ma'am, Dr. Satanshu Mathur sir, Dr. Neeta Dodwad ma'am, and Dr. Kimaya Chauhan ma'am. And Dr. Sahu is the founder chairman of ISMSICS. He was the past president of Bombay Ophthalmological Society and is a nationally and internationally acclaimed cataract surgeon who has introduced a 2 mm MSICS technique. Dr. Sahu is the founder chairman of the Sahu Group of Hospitals in Mumbai as well. Welcome, sir. Next, we have Dr. Boramani, sir. Dr. Jagannath Boramani is the executive chairman of ISMSICS. He has pioneered and popularized SICS under topical anesthesia. Being a recipient of multiple awards, he is also well known for his X-chopper for closed chamber manual phaco-fragmentation as well as customized incision cataract surgery. Welcome to the advisory board, sir. Next, we have Dr. M.S. Ravindra. Dr. Ravindra sir is the medical director of the Kartik Netralaya, Bangalore, and he is one of the most respected and renowned doctors in the field of ophthalmology. He brings with him a great amount of experience in the field of cataract and vitreoretinal surgeon. Welcome to the group, sir. Next, we have Dr. Harsha Bhattacharjee. He is the founder and president of Sri Shankardeva Netralaya, Guwahati, Assam, and he is also one of the most respected and renowned doctors in ophthalmology. And he brings with him another great amount of experience in the field of cataract, and he is also a vitreoretinal surgeon. Welcome on board, sir. Next, we have Dr. Manisha Rathi, ma'am. She is the head of glaucoma, RIO PGIMS Rohtak, and she is well known for her talk on the role of simulator in MSICS and the chevron incision in MSICS. We welcome you to the advisory board, ma'am. We have with us Dr. Satangshu Mathur, sir. He is in Kashipur, Uttarakhand, and he has contributed as an expert for customizing guidelines for SICS and the present recommendations. He is a surgeon par excellence. Welcome, sir. We have with us Dr. Neeta Dodwal. She is the medical director of Brahma Netralaya, Gurunit Welfare Foundation, Mumbai, and also the joint secretary of the women's wing of ISMSICS. And she is the medical director of Rotary Club of Mumbai and honorary surgeon at the Prasad Chikitsa, Ganeshpuri. Welcome to the advisory committee, ma'am. Next, with us, we have Dr. Kimaya Chavan. She has an experience of 21 years of practice at the Chavan Hospital, Mumbai, and she has worked as SICS trainer in Lions Hospital, Miraj. She has conducted many camps in SICS, and at present, she is the joint secretary of the women's wing of ISMSICS. Welcome, ma'am. So with that, I would like to invite Dr. M.S. Ravindra, sir, to kindly share his thoughts on this platform.
Thanks to all the people who have assembled here, especially the youngsters. You have a big mantle to carry forward, and I'm sure you're very capable of doing this. Only one thing I would like to share here is that we all, whenever we meet somebody, we all are so proud of doing phacoemulsification. Phacoemulsification is the way to go, but then with as much pride, we should say that we are SICS surgeons. So the name of SICS has been trampled by the trade. They want to promote, the machine surgery, while we would like to promote artistic surgery. At the end of the day, the results of artistic surgery is far, far superior in a majority of cataract patients. And keep in mind that there's nothing wrong in saying that you are an SICS surgeon. And one secret I would like to give, especially for youngsters, is that you will be richer when you are an SICS surgeon. See, much of the money that patient pays towards cataract surgery goes towards consumables and towards the industry, while much of the money it's the same amount of money you pay for the cataract surgery. A larger portion of the money remains with you, and that way you will see much brighter future, brighter days. Practice both the techniques, not one is inferior to the other one, but give the option of the best the patient deserves for his or her eye condition. With that, best of luck and best wishes.
Thank you. Thank you so much, sir. Sorry. For your encouragement and always inspiring us to move ahead with SICS. May I now request Dr. Neeta Dodwan, ma'am, to kindly share her views. Ma'am.
Yeah. Thanks, Dr. Nilutparna, and I thank all the seniors for having me on this advisory board. I really want to congratulate on this platform to the all young ophthalmologists taking part in such a good initiative and taking pride in doing small incision cataract surgery. So congratulate and best wishes for all the young dynamic team. Thank you so much.
Thank you. Thank you so much, ma'am. We are really honored to have you on board. May I now invite Dr. Kimaya Chavan, ma'am, to kindly share her views on this platform. Dr. Kimaya, ma'am?
Yeah, I'm audible now?
Yes, ma'am.
Yeah. Thank you so much, Nilutparna. First of all, Happy New Year to everyone. I would like to thank our founder chairman, Dr. Amulya Sahu, to believe in me and giving me the responsibility. I'm very happy and excited with all the charming, energetic young colleagues of mine. And I will definitely help them out whenever they want any help from us. Thank you so much.
Thank you so much, ma'am. We look forward to working under your guidance. Thank you so much. So, Dr. Harsha Bhattacharya is currently traveling, so he will not be able to join us right now. He sends his warm wishes, and he also wishes that he looks forward to seeing the young brigade in the MSICS group. Professor Manisha Rathi, ma'am, also could not be reached as I think she's out of station, and she gives her best regards for this installation ceremony. With that, we move on to the installation of the mentors of this IS-MSICS EO chapter. We have with us Dr. Deepak Mishra, Dr. Praveen Subudhi, Dr. Manas Nath, Dr. Aarti Heda, Dr. Vishwajit De, and myself on board to be mentoring this EO chapter. So Dr. Deepak Mishra is currently the Associate Professor, RIO at Banaras Hindu University, Varanasi, UP. He's the Chairman Scientific Committee of UPSOS and the Joint Secretary of IS-MSICS, National Convener Surgical Skill Transfer Course, and the founder of the PG Examination Forum. We welcome you on board, sir. Next, we have with us Dr. Praveen Subudhi. He is currently the consultant at the Ruby Eye Hospital, Behrampur, Odisha. He is the ex-consultant cornea and refractive surgery, Arvind Eye Hospital, Madurai, and the teaching faculty at High Tech Medical College, Bhubaneswar. Welcome, sir. Next, we have with us Dr. Manas Nath. He is currently working as a senior consultant at the ASG Eye Hospital, Kolkata, and he has worked as the HOD of the cataract services in Arvind Eye Hospital, Pondicherry till 2019. He was responsible for teaching cataract surgery to the national and international candidates there. And he has also completed his anterior segment clinical observership under Dr. David Chang, Dr. Jeffrey Tabin at Stanford, and Dr. Alan Crandall at the Moran Eye Center. Welcome on board, Dr. Manas. Then we have another young Dr. Vishwajit De. He says the teaching is my passion apart from learning continuously. And he is the founder director of Modern Eye Care and Super Specialty Clinic Cuttack, and also the Sai Netra Mandir Eye Hospital, Chandigarh. His previous affiliations are that he had been the consultant at the Pediatric Ophthalmology and the Squint Services at Arvind Eye Hospital, Pondicherry. Welcome, Dr. Vishwajit, to the group. Next, we have the young and dynamic Dr. Aarti. She is currently the consultant and anterior segment surgeon of Pune, working at Pune, Maharashtra. She is also the national and international coordinator for the IS-MSICS. She is an associate editor of the Global Journal of Cataract Surgery and Research in Ophthalmology. She runs a webinar series entitled The Surfing of the Anterior Segment under the aegis of EOC, and in charge of the masterclass webinar series under Eye Today. Dr. Aarti had worked as a consultant in Africa for 4 years, handling all the anterior segment surgery. Welcome, Dr. Aarti. Actually, you are the family of IS-MSICS. I think, Dr. Aarti, over to you.
Dr. Nilutparna. So Dr. Nilutparna, I'm grateful to you that you have taken this forward and you are joining the list of the mentors here. Dr. Nilpana is currently conducts teaching and training of residents at Shri Shankardeva Netralaya, Guwahati, where she is the associate consultant in the Department of Strabismus and Pediatric Ophthalmology, responsible for ocular genetics and myopic control clinic. She takes pride in being Dr. Sahu's first student in learning the 2mm SICS technique. So thank you so much, Dr. Nirutwana. Over to you.
Thank you, Dr. Aarti, for such a warm welcome. And I'm honored to be Dr. Sahu's student for the 2mm SICS. So among the mentors, I would like to invite Dr. Deepak Mishra. Sir, could you kindly share your thoughts on this?
Hello. Good morning. Good morning, everyone. Thank you, Dr. Nilutmara. And I'm saying today revealing one secret that this Yo chapter is basically the brainchild of Sahu sir and Boramani sir. Both had given responsibility to me and Aarti almost 1 year back, that you have to coordinate with someone from ISMICS, someone from Yo chapter, and you have to make something which is more vibrant and more active than our all the present chapters. And we expect the same from the Karan and everyone. I'm happy to see like Raki, Karan, Bharat, everyone. I'm knowing them personally for a long time, and they have doing good in SICS, not only in the surgical skill, but in the publication too. Kiran is also there. So my best wishes to this chapter, and I hope under the guidance of each and everyone, this chapter will achieve what Sahu sir has a dream for it, and we will work together, and happy that all my good friends are here. Thank you. Thank you.
Thank you so much, Dr. Deepak Mishra, sir. May I now request Dr. Praveen Subudhi? Sir, could you please say a few words?
Good morning, everybody. Thank you, Nilutpana, for giving me this introduction. And at the outset, I'd like to thank Amulya Sahu sir for envisioning this forum and doing excellent work in SICS. And first of all, Happy New Year to all of you. So now we all know that we are in the business of vision, and we should give the best services to our patients. No matter whatever technique you follow, we execute. At the end of the day, patient needs to be happy going out from your hospital. So SICS is a very, very good surgery when it comes to complicated cases. Yesterday only I had operated one where the patient had one-eyed and had a significant corneal scar, and the other eye was patient had lost his vision because of retinal detachment and everything. So in these cases where phaco can be risky and you may land up in trouble, and there is a drop in the nucleus and all these things, the patient will the eyes will be completely ruined. So SICS comes as a savior. So definitely for every youngster, whoever is learning phaco, yes, phaco is the future, but they need to learn SICS also, because I was in Arvind for almost 7 years, and during my course of 7 years, I had performed a lot of SICS surgery, and it helps me in cornea also. If you learn a good SICS technique, it will help you in other intersegment surgeries also. Like if you want to perform for a cornea surgeon performing DSEC, you need to be mastering the tunnel. So tunnel construction in SICS is very, very important. And in this way, you can learn other surgeries also, like SFIL and everything. So with these few words, I would be more than happy to mentor the youngsters and promote SICS in an international platform in whatever capacity I have. So thank you very much, and welcome. I welcome all of you.
Thank you. Thank you so much, sir, for your encouragement and your guidance. So Dr. Manas is not able to join us because he has his commitments at the OPD today. And do you have Dr. Vishwajit Day here? I don't. Okay. So moving on to the office bearers. So we look forward to the able leadership of the president, the secretary, and the chairman of this society to lead the young brigade. And to introduce to all of you, we have Chairman Dr. Karan Bhatia, President Dr. Nandini Chandak, and the Secretary Dr. Raki P.D. Cruz for the Yo chapter of ISMSICS. Dr. Karan Bhatia is currently the Assistant Professor in the Department of Cornea Services and Head of the Academics at RIO Sitapur, Uttar Pradesh. He is the Joint Secretary of YOSI and also the Editor-in-Chief of the YouTube. So welcome, Dr. Karan. And congratulations on being the chairman of this society.
Thank you, ma'am. Thank you.
Okay. Next, we have Dr. Nandini Chandak. She is a consultant ophthalmologist, a cataract refractive surgeon. She is also taking care of the glaucoma and the medical retina clinic. She is currently working at AMRI Medical Center, BBI Foundation, as well as the Eye Clinic, Kolkata. Welcome, Dr. Nandini, and congratulations for this honor.
Thank you, ma'am.
So we have with us Dr. Raki PD Cruz. I would like to introduce her as from her words. My short-term goal is to achieve the best out of the institute I work while delivering good quality work and surgeries. My long-term goal is to establish myself as an able and versatile young ophthalmologic surgeon and as an enthusiastic teacher and researcher. We welcome you, Dr. Raki, and congratulate you on this honor.
Thank you, ma'am.
So moving on to the young brigade that we have with us, the scientific committee will consist of the able Dr. Manik Nicholson. She is hailing from Maharashtra. Welcome, Dr. Manik. Dr. Aparna Nayak from Karnataka, Dr. Dipanjan Ghosh from Assam, Dr. Abhijit Patil from Maharashtra, Dr. Prashant Girish from Tamil Nadu, and Dr. Bharat Gurnani from Pondicherry. We welcome all of you to the family of ISMSCIS and the Yo Chapter Scientific Committee of ISMSCIS. Then we have the executive members of this chapter, Dr. Rammohan Paidi from Andhra Pradesh, Dr. Kirandip Gurnani from Pondicherry, Dr. Sovik Borwa from Assam, Dr. Aman Khanna from Delhi, Dr. Anuprita Gandhi Bhatt from Maharashtra. Congratulations to all of you and welcome. Chapter. So before we embark on the topics that we have decided for today, may I now request the office bearers. Dr. Karan, would you like to share a few words?
So this is a very exciting opportunity. I've always believed SICS is the backbone of all surgeries. And if you can do SICS, you can do any surgery. It really makes things easy. And it's makes difficult situations, easy to handle. What you do in a surgery is, this is what I believe is to give the best results with the easiest method. And SICS makes it possible. So thank you so much for all the seniors and Nilutparna ma'am and Aarti for this. The best we can and hoping for a really prosperous new year.
Thank you so much, Dr. Karan. Dr. Nandini, would you like to share?
Yes. Thank you so much for this opportunity to the IMSICS. Joining this group itself is very heartwarming in the new year. So definitely, as Karan and our seniors have said, we need to know SICS because that is the savior. Even when we do phaco and there are complications, we need to resort back
Thank you everyone for giving me this opportunity, and I'm proud of.
Thank you so much for this opportunity, Dr. Nilutparna and Dr. Aarti. I would like to thank my seniors and under their guidance, we would definitely...
Syed, please mute Dr. Dipanjan.
Hello.
Dr. Dipanjan, please mute yourself.
Okay.
Dr. Nandini?
Nandini, you kindly mute yourself and talk.
Okay. Am I audible now?
Yes, you are.
Yeah. Thank you so much for this opportunity, Dr. Nilutparna, Dr. Aarti, and thank you all my seniors. I definitely look forward to working in this group where SICS is promoted, because even when we know phaco, we need to understand the basics of SICS because that comes as a savior. Whenever we have any complications, we need to resort to our basics. So SICS is the way to go, and with the forward, we want to take it forward with this team that we have, and under the able guidance and leadership of the seniors. So thank you so much, and wish you all a very happy new year.
Thank you. Thank you so much, Dr. Nandini. Dr. Raki.
Hi, first of all, a very happy new year to everyone. I wish that everybody will be having a very wonderful and grateful new year. And thanking all my seniors, especially Aarti ma'am, Deepak sir, and Nirupama ma'am for giving me this opportunity. I will do my best to the position I'm chosen for. So for me as a beginner, I am more comfortable and confident in SACS than FACO. So whenever I'm doing any FACO case and I face difficulty in any situation, I'm very much happy that I can convert as soon as and give the best for the patient. So I think it is always necessary that rather than jumping to learning FACO and doing more cases of FACO, you should first know the basics of SACS and be confident so that you can face any difficult situation and any difficult cases. Thanks once again.
Thank you, Dr. Raki, for your lovely talk. So from the scientific committee, not in any order, but may I request Dr. Manik Nicholson to share her views. She'll be sharing her PPT, but before that, would you like to say something, Dr. Manik?
Yes, ma'am. Good morning, everyone, and Happy New Year to everyone. Thank you, ma'am, and Raki and Karan for this immense opportunity and for allowing me to be a part of this wonderful new dynamic team. I hope to give my best to this team and we take it forward in the new year. And especially a huge thank you to Dr. Sahu and Dr. Boramani for your faith in me and constant support. And Dr. Kimaya and Dr. Nida for hand-holding me right from the beginning through my journey in ISMSICS. Thank you.
Thank you so much. And then moving on to Dr. Dipanjan, would you like to share something? A little?
Yeah. Hello, am I audible?
Yes. Please go ahead.
Stop sharing the screen.
So first of all, thanks to Sahu sir, Boramani sir, Parikshit Bhokte sir. I have been a part of this journey of ISMSCS, and today I think it is actually a great achievement for both the societies, like the installation of the EO into the ISMSCS. And as sir has already mentioned, like it is the one reason us to take SICS further, and hopefully we can work on it. Thanks Dr. Karan, Dr. Nirupama ma'am, and Aarti for having me in this scientific committee, and I believe we can take SICS to newer heights. That's all.
Thank you so much.
Yeah, thank you.
Nirupama, you can stop your screen share.
Okay. So do we have Dr. Aparna is not able to join us. Dr. Abhijit Patil, do you have with us? No, I don't think so. Dr. Prashant, would you like to share something?
Very good morning to everybody and a happy new year. I'd like to thank all the office bearers and the team behind the development of this platform. And also a big thanks to Dr. Karan, Aarti and Nirupama, who has been working in to get this application and platform ready. And of course, we all know SICS has always been the backbone in developing countries. It has always been, and always the complex case managements. And we've done a lot of work anyway in SICS in India as well as in other parts of the world. And a platform like this will definitely help to enhance the training programs in SICS, not only in India, but globally. And also for the young ophthalmologists coming up, it is a must learn surgery, I think, in today's era of time. Thank you.
Thank you so much, Dr. Prashant. Dr. Bharat, would you like to say something?
Yes, ma'am. Good morning, all respected senior faculty, and wish you a warm happy new year to everyone. Really thank Dr. Karan sir, Dr. Nirupama ma'am, Dr. Prashant sir, Dr. Deepak sir, all for giving me this opportunity. I'll try to contribute my best to the responsibility what has been embarked on me. And I'll especially want to thank Prashant sir for teaching me all during the years, as I said, Arvind, and I am really lucky to be a part of this. I really thank all of you. Thank you, ma'am.
Thank you so much. And last but not the least, we have Dr. Aman with us. He'll be sharing his PPT. And before that, would you like to say something, Dr. Aman? So, okay, I think he's on mute.
Yeah.
So,
Can
Aman,
we
you're
start
there?
with the talks, Dr.
Yes.
Yeah.
Yes, we are starting. He's the last person to say.
Yeah, I want to thanks all the office bearers and to initiate this chapter, and thanks a lot to Dr. Karan and Dr. Nilutran ma'am for including me in this chapter. Actually, I did my fellowship from Sadguru Netra Chikitsalaya Chitrakoot, where SICS is still one of the most leading surgeries that is being done, and that is what is taught there, that SICS is your basics. So I'll be really excited to be involved in this group and take this the next level. Thank you.
So with that, we come to the end of installation of all the office bearers and short talk from all of them. We move on to the topics that we would like to discuss today. So first and foremost, I would like to invite Dr. Manik Nicholson to share her talk.
Thank
Dr.
you.
Manik.
Thank you for an excellent installation ceremony, and congratulations to all the people who are installed. We hope to make this a very fruitful and good organization. So Dr. Nilutparna gave me this topic, Residency Program for Teaching in SICS. And as I finished making my slides and looked back at all my slides, I realized it was actually what my sorry, my screen has hung. Just let me start this again. Am I visible? Is the screen visible?
Yes, Dr. Manik, it is visible.
So I realized when I look back at my slides that it was actually something, it was my journey through SICS and what SICS had taught me. So I thought the best outline for my presentation would be in these three formats: my learning from my years undergoing training, my learning from my years training others, and where I think the future of SICS lies. So I'll start from the learning I received from my years undergoing training. I did my residency at the LV Prasad Eye Institute in Hyderabad, followed by a short 1-year fellowship, 15 months at Narayan Nethralaya, and then another 1-year fellowship in cataract surgery at Haji Bachwali in Bombay. So during my residency in my first year, we were encouraged to go to the wet lab. We had a nice wet lab, and we were encouraged to suture corneas starting in our 5th to 6th month. We had to show around at least if not 10 to 15 sutured corneas to a senior cornea surgeon who would assess them and give us pointers on how to improve. We started SICS training in our first year in around possibly the 8th or 9th month. This was under the supervision of usually a senior fellow and then usually a junior consultant. And the advantage of being there was that all our videos were recorded, and we, in fact, all of us as junior residents maintained a detailed journal. We would go back to the AV department, collect CDs of our surgeries and put them in a little envelope and staple them in our diaries and write down all the steps of surgery which we had done and go over those videos. It was very useful to self-audit your videos in those initial stages. Through the second year, we progressed to having independent resident OPD ORs, and this gave us a lot of confidence. However, all our cases were always assessed by a senior consultant, and they were checked out by a senior consultant. We had frequent case and surgery audits where our surgical case videos were assessed by a senior fellow or a consultant, and our cases were taken over, especially when a complication occurred or when the cases were taking too long. And something which I was exposed to during my residency was the ICO Oscar grading system, which was used by trainers. This is just a snapshot of what it looked like. It's actually quite a detailed SICS competency scoring system. The ICO has graded each step of SICS surgery into 4 grades, and the trainer is advised to give a score depending on your surgical skill at the end for each step. And this is tallied, and you can sort of over the period of 6 to 8 months keep a track of your score and also see where you are faltering and maybe give a little more attention to that step. During my final year, we were posted at a peripheral center. Mine was a village called Thudukurthi, which is around 200 kilometers from Hyderabad. We were posted as 2 ophthalmologists independently running that entire center. I was the senior resident, and this was a senior fellow who was posted with me, Dr. Badruti, and we became very good friends at the end of 6 months. So we had an alternate day of OPD and OT, and I think this was one of the best learning experiences of my life because it sort of pushes you to be more independent instead of having some senior fellow or a consultant as a crutch to always fall back on. So I learned to manage complications myself. I learned how to run a center independently. I was mentored by a very good senior fellow, and we sometimes did have visiting faculty to help us with more difficult cases. And one incident which I remember vividly, and which even Dr. Padmaja, who's a senior consultant at LVP, remembers, is during my initial stages over there, in my initial months over there, I had a lot of complications in SICS. I struggled a lot with my tunnels. And I reached a point where I wrote an email to her saying that I wanted to quit cataract surgery and I wanted to quit being an ophthalmologist because I was so dejected that I had so many complications in my initial stages. And my senior fellow, and along with a number of consultants, handheld me. They called me back to Hyderabad for a little further training, and that helped bolster my confidence there. So my fellowship was at Narayan Netralaya. It exposed me to a very different side to cataract and refractive surgery. I trained residents and fellows there. We also were exposed to wet labs for SICS and phaco. I had two very good mentors in the form of Dr. Matthew and Dr. Sudeep. What we learned there was how to train residents in SICS at our other center. Our teachers waited in the OR after every surgery and would go over video recordings of our cases and point out mistakes and where we could possibly improve. And something which I learned in my fellowship was how to edit videos, but I also learned that while editing cataract videos, it gives you the advantage of going over each step repeatedly, maybe even possibly up to 20 to 30 times, because you have to keep editing that one step. And doing something like that helps you realize smaller things which you may otherwise not realize while sitting next to a surgeon observing them operating live. I then moved on to a fellowship at the Haji Bachwali Eye Hospital. This is a high volume SICS center, as most of us in Bombay know, with many large camps and many CPS candidates as residents over there. What I learned over there is high volume centers like these help you increase your confidence in SICS, and not only training, but also managing complications of yours as well as other trainees. It taught me how to conduct camps and quickly screen patients, because earlier I was more dependent on ancillary staff optometrists. And this sort of an exposure helped me develop greater dependence on my own clinical acumen. And this was, of course, helped by a great mentor, Dr. Suvira Jain. I then did a short ICO fellowship at the Massachusetts Eye and Ear Infirmary. There, it's mostly phaco. But what I realized over there is that SICS is a great rescue operation. And many foreign surgeons are in awe of the volume and speed of surgeries that we do in India. And they all want to learn SICS, although there is a poor training infrastructure for SICS there, possibly because surgery over there is more company driven. And my mentor, Dr. Pineda, was a great proponent of SICS. He's visited India many times and is also an excellent SICS surgeon himself. So after that, I wanted to talk a bit on what I learned from training others. I was a consultant in the cataract and refractive department in LV Prasad at Visakhapatnam for a while, after which I shifted back to Bombay and pursued a private practice there. And a couple of years back was exposed to ISM SICS as well, and I'll talk a little bit about that. So at my time in LV Prasad, I was given the opportunity to head the education department. And what I realized through my time over there was that most fellows are eager to learn SICS, and there's always that feeling that most fellows want to learn phaco. But that's not true. Most fellows are eager to learn SICS also. And this is especially true for international fellows who are very, very keen on learning SICS, especially when they come for these short fellowships. Many international institutes are now giving importance to SICS as an important surgical tool. What is important to teach, apart from clinics and the practical bit of SICS, is also some amount of theory in SICS as a starting point for training. And it's important to have a discussion prior to starting each case and after ending it. This I've realized is necessary, because most people only talk to you at the end of the case and point out your mistakes. But if you have some difficulties, it's necessary to talk to your senior or mentor at the start of a case as well. Patience is a virtue. This I've learned the hard way, and this I think most trainees who are in their training phases will relate to as well. As if you spend time mastering each step, it takes time, and it is a virtue. And it's important not to be discouraged if you get things wrong at the first go. We usually used to urge fellows to do another case if they've had a complication, or do a few steps in the next case, just so that they don't lose morale. These I realized were a few choke points. The three main ones, which most of us are aware of, are trainees assessing tunnel depth, getting the size of the rexes right, and possibly the most infamous one, dialing the nucleus into the AC. These were some of the questions which plagued me during my time there. Which month should residents start training in SICS? How many practice cases in the wet lab should they do? How many cases should they observe? When should a mentor take over a case from a trainee? And how to mentally train a resident or a fellow to not lose confidence after a complication? And when should one analyze the complication? Should they do it immediately after they've had it or maybe at a later time? And when is a trainee fit to start operating independently? Are there any variables which should be laid down for the same? These are some questions which we could later on as a joint organization address. I was also given an opportunity through LV Prasad to team up with the Fred Hollows Foundation and go as an SICS trainer to Inner Mongolia in a city called Hohhot in northern China. And we went there and we realized that there was such a vacuum in learning SICS. We created SOPs, training schedules, self-evaluation forms, and conducted rounds of lectures, even did a few surgeries. These were some of the self-evaluation forms that I gave them. Basic forms, just complications as well as steps within surgery and how to sort of follow them up over a period of time, details of each surgery as well as a final tally so that they could see their progress over a week or a couple of months. I then went back to private practice. I realized that SICS is an extremely rewarding surgery in private practice, especially in hard cataracts, where in private practice, what is more important than what surgery you do is the wow factor. And SICS in hard cataracts, complicated cataracts gives you that. It's an excellent rescue operation from difficult surgeries as well as in complicated cases. I also resorted to SICS very much when I needed to do high volume work, train residents. This was a camp which we conducted at Kurla, and this was the owner of the camp. He's 94 years old. He was so fascinated with the surgery, he got SICS done on himself and with excellent outcomes. This was a camp which we regularly go to once a month in the outskirts of Maharashtra in an area called Talwada. It was founded by Dr. Muljiani and now taken over by Dr. Jahangir. We trained residents in SICS. Initially, there was a little difficulty in sort of training the staff to start SICS because they didn't have the blades, they didn't have cautery, they didn't know what the steps were. But you realize that after you train staff and you teach them, they themselves see the value of SICS as most patients have a faster recovery, better visual prognosis, less pain on the first post-operative day, and you also you also realize it's quite cost-effective and efficient. So ISM SICS, which I joined now possibly 2 years back, has been a huge eye-opener for me. It has provided me with some excellent teaching videos, newer concepts in SICS, mentorship from stalwarts, excellent camaraderie amongst seniors and juniors, and huge opportunities to grow and to be recognized. I thought I knew most of what was in SICS, and ISM SICS has truly humbled me because I realized I've not even scraped the surface of SICS. I still have so much to learn. Dr. Sahu's 2mm microincision SICS surgery, Dr. Ravindra's phacosection, Dr. Boramani's manual phacofrag, Dr. Devashish's irrigating vectors technique, Dr. Anil Shah's snare technique, to name a few. There has been so much work which has happened thanks to ISM SICS in the space of SICS surgery over the past couple of years, and we still have so much to do. So where I think the future lies is in teaching techniques, including wet labs, where ISM SICS has teamed up with Help Me See to provide this, to sort of give avenue to this venture. Online training programs where I think ISM SICS is at the forefront, and we will be soon launching our GSICS training program as well. Informing international chapters to spread the word of SICS and hopefully start training programs as well. Creating mentorships for trainees, which I think is essential and must be maintained lifelong. Something which Dr. Ravindra spoke about just now, glamorizing SICS. I think the onus of glamorizing SICS as against phaco lies on us, as against in surgeries such as phacoemulsification, where it is more company driven. So I think that is something which is, especially as young ophthalmologists, we should focus on. And the last thing, and I think possibly the most important thing, is passing on the torch, or as I like to call it, paying it forward. I was, this is something I want to quote. I was once in an AS, this is my last slide, sorry if I've overshot time. I was sitting in an ASCRS concert and Dr. David Chang was giving his commemorative speech. And I would like to use his exact words for this because I don't think anyone else can say it better. These are his exact words. Although every year it gets increasingly harder to practice medicine, I'm continually reminded that we still belong to one of the most stimulating and rewarding of all professions. I would like to highlight a few core values of our profession that I hope to continue and embrace and foster. These values were passed down by the generation of physicians that trained and mentored us and have survived decades of adverse economic and political pressures. The most important of this core value is our remarkable willingness to teach and help each other. As busy clinicians, our personal time is precious, and yet I know of no other profession where so many of its members regularly volunteer so much of their time to teach others the skills to become as good as the teacher. The expression paid forward describes the unselfish concept of having someone repay your good deed not to you, but to rather a future stranger. We teach residents and colleagues not because of an obligation or compensation, but out of appreciation for those who so generously taught and mentored us. Medicare is trying to define, measure, and incentivize quality care, but this teaching that we do is priceless and immeasurable in its value for bettering patient care. So I think ISM-SICS has given us all an opportunity to pay it forward, and this is something I hope to strive and do through this organization. Thank you very much.
Thank you, Dr. Manik. That was an excellent presentation and exceptional.
Can I come in, Nilutparna?
Yes, sir. Yes, sir.
Yeah, Manik, you have so much you have given me to think about. We are planning after this, our platforms are all complete. After we have launched the National Governing Council and that Finance Committee, the platform vision will be complete. Then we will be focusing about the training that in SICS, and Manik, I see you will play a big role in that, and Nilutparna and Arthi, you just focus on her. She has got such a clarity in her presentation and so much of, she's a quiet worker, and I'm really, I feel so rich by your presence with us, and looking forward to, and you have all the people, Ms. Ravindra and all this Brahmani, Parikshit, everybody is there with you, and I want to take it forward, this training program to every colleges. It should be a mandatory that they should be trained, and Manik, you are going to play a big role in that.
Well, thank you. Thank you.
I think Sahu sir has actually summarized the entire presentation. Congratulations, Dr. Manik, and I really appreciate the effort that you have taken, especially to self-assess the students so that they can assess themselves since the initiation of the residency program. I would like to request all the youngsters who are watching this to kindly follow this presentation on YouTube, and please take the inspiration from Dr. Manik Nicholson. Thank you so much. It is an honor and privilege to have you on this board. May I now request? Thank you. May I now request Dr. Karan Bhatia to kindly start his presentation.
Before starting my talk, I would want to congratulate Dr. Manik for that wonderful, big summary of, the training program that she has given. It was a really excellent presentation, as the others have echoed. So my talk is SICS in weak zonules. So the preoperative workup in such situations is extremely critical. One should look for phacodonosis in the undilated pupil, and then you can dilation and then look for flattening of the lens periphery, as you can see over here. You should look for predisposed conditions, like pseudoexfoliation or trauma. And if there is vitreous in the anterior chamber, the order is first the vitrectomy you have to do, and then go ahead with the lens management. So in such cases, keep your tools ready. So you have to be prepared for any complications. So keep your CTR, the Sionis ring, or the CTS. You should keep all of these things ready next to you in the OT. So capsular staining is extremely important. Trypan blue, it makes it tough and makes it more rigid, so it makes it the ALC, so it makes it access a little bit easier. And dye, but you have to be very careful that dye can escape into the vitreous cavity. So CCC is most often the first indicator. As you can see over here, the lens is shaking in this video. So this is the first indicator that the patient has got weak zonules. So in such a case, it's always better, to make, don't struggle too much with the cystitome, and it's always better to shift to a utrata, because a utrata will make, induce a little bit less pressure on the zonules of the lens. This is another case. As you can see, there is a lens coloboma inferiorly. So rhexis was started off, with the cystitome. And then later on, I shifted on to my utratas, and then utrata, with utrata, you can do it. This is another case. Now, this is a hard cataract, the typical iris coloboma. And there are weak zonules inferior. It doesn't have a coloboma, but you can see the rexus initiation was extremely difficult, and there are a lot of plaques. I tried to cut it, getting a little bit more difficult. Then went in with the micro scissors. Now, in such a case, phaco would actually be, quite difficult surgery. So, cut it with the 2 micro scissors from both sides, and then made it sort of a rexus with the utrata. And this is what the beauty of SICS is. You can handle such rock hard cases and give excellent results, which would be really difficult with a micro incision surgery like phaco. So CTR, I'll explain the saying that as early or as late as possible later on. But in such a case, you can implant it earlier on with the nucleus in place after hydrodissection. So this helps to stabilize the lens. And over here the CTR was lost. You have to be very careful. You have to use two dialers or 2 Sinskis and make sure that it doesn't slip into the sulcus, because then it becomes difficult to retrieve it. This is another case. So when you're putting a CTR over here, the nucleus has been removed. The next thing is to inflate the bag. Now you can do this with a dispersive OVD, and then you can insert your CTR in the normal fashion. Again, it has to go into the bag, and one has to have an intact CCC before putting a CTR. And then again, using 2 hands, and the second hand, just to prevent the slippage of this CTR. This is another case of a coloboma eye. And then again, CTR was implanted after there was after the nucleus was removed. This is another case. Again, CTR was implanted after the IA was done, because there was phacodonosis in the case, and the case has weak zonules. Even in cases of pseudo exfoliation, it's often a better idea to implant CTRs. and helps to stabilize the bag. So as early or as late as possible, because you can implant it early, but the main thing is to implant late, is that the cortex aspiration becomes extremely difficult when you've got a CTR in place. So you have to go underneath and pull it out. That is the main thing that you have difficulty. Otherwise, I prefer to implant it as late as possible, but whenever there is a requirement, you must put it. So the nucleus management is actually the real advantage of the SICS. In such a case, doing phaco, you have to be extremely careful. You have to sometimes go into the anterior chamber to manage such cases, and you don't want to do it. And this is so easily comes out with SICS. And look at this hard cataract. Now, this was the same coloboma eye, and you can see with this SICS, I was able to bring this nucleus out into the anterior chamber. Doing phaco in the bag in such a situation with the rexus, in doubt, would really be a difficult thing. And with SICS, the patient had, you can have a clear cornea next day, and makes it easy. Again, with IOL insertion, once you put a device, a CTR or a CTS in place, and then you can implant IOL in the bag. A 3-piece IOL should ideally be implanted into the sulcus, and a single piece into the bag. Single piece one, if there's an area of zonal dialysis, what one has to do is that basically in the area of the ZD, that is where you put the haptic in such a way. So it's an inferior ZD, you would put the lens vertical position, so the lens haptic acts as some way like a CTS. But if you're putting it in the sulcus, a 3-piece lens, then you have to put it 90 degrees away. In cases of absent capsular support, this lens really does come to the support. Again, you need tunnels over here, so the SICS has a big advantage. And whenever I feel that the bag is not stable and it's too weak, I prefer to take out the bag and do an iris claw or an SFR at the same sitting. So this is very simple while implanting an iris claw lens. After putting it inside, and then you can just tuck it with the dialer or a hydrodissection cannula. And similarly is done for the other side. And this lens is do pretty good and stable. And then followed by a PI is absolutely must. You can do it manually or with the vitrectomy probe as well. So the other one is like, if suppose sometimes the iris is not good enough, then what you can do is the SFI. I prefer to do this technique that we had published in the Indian Journal of Ophthalmology by the name of mixed technique, which is a modified adaptation of the Yamane and the Exnick techniques. So via scleral tunnel, it really makes it possible. So what we are doing over here is basically we're externalizing a 3-piece PMMA haptic, and once this is done, similarly it is done for the other side. So this is all done via sclerocorneal tunnel being shifted slightly towards this side so that it's closer here, and basically this allows the needle to come out, and once it's out, like the X-nick technique, it really makes it's not so difficult. You can do an SFIR in about 10 to 15 minutes. After this, again, it's a cheaper surgery. I'm using the Orolab 3-piece lenses over here, and they're pretty cheap. And then you can trim the haptic a little bit, and I prefer to trim them to avoid pseudophacodonosis. And I want the lens to be taut when it's inside the eye, and then I create a flange on either side. And once this flange is done, it is buried, intrasclerally. And patients have done extremely well in such scenarios. I've combined the surgery with the DSEC, with PK, everything, and these are the results. Patients do have a good recovery, faster recovery as well. So to conclude, SICS is the backbone of all the eye surgeries, and it makes difficult situations easier to handle. Thank you so much.
Thank you so much, Dr. Karan. That was exceptional surgical video. You have shown such great skills. Thank you so much for doing such excellent SICS and teaching the youngsters, as well as through your teaching program and training program, as well as through the YouTube. Thank you so much. Now we have Dr. Raki De Cruz with her presentation. Welcome, Dr. Raki.
Yes, ma'am. I will be sharing my screen.
Yeah.
Is my screen visible?
Yes, it is visible.
Hello, everyone. I'm Dr. Raki. Again, wishing you all a very fruitful new year ahead. So today I'll be talking on managing astigmatism with SICS. So as surgeons, when we get a 20/20 best corrected visual acuity in the first postoperative day, most of us are very happy. But some patients are not happy because they were expecting a 20/20 unaided visual acuity. And even some patients want to read without glasses. So the spherical power can take care of spherical power can be taken care by the accurate IOL. But what about the cylindrical power? Even the cylindrical power can be taken care by the cataract surgery nowadays because it has evolved into a refractive surgery. But still the near vision problem persisted. So astigmatism in SICS versus phacoemulsification, we all know the SICS has got a little more astigmatism when compared to phacoemulsification. But this small astigmatism can aid in giving the patient a better near visual acuity. So by carefully doing a good SICS surgery and by pre-planning the incision, we can manipulate it in such a way that it can give a multifocal IOL-like effect, which gives the patient a better near visual acuity. So this was a meta-analysis paper by Gokate et al., which has compiled nearly 80 papers and comparing SICS versus phacoemulsification, and it has stated that nearly 81% of the SICS patient had unaided near visual acuity better than N18 when compared to 19% of phaco cases. So how to minimize this astigmatism? This is something which you all might be doing, but I'll just race through it. So size, as we know, smaller incisions are better. Astigmatism is directly proportional to the cubic root of length. Among the different shapes available, Frown and chevron incision are the best for the astigmatic neutrality. And side, we should always measure the keratometric radius very carefully, and we should pre-plan our sides. When it comes to astigmatism, temporal incisions are better. Again, one more thing, pre-existing astigmatism, we have to be very careful about the pre-existing astigmatism, its axis. Make sure you get a careful care readings, and if needed to get a topography also. And always try to choose a steeper meridian to operate. The Cox astigmatic funnel, as we all know, incision within this funnel are astigmatically neutral. Frown incision is one of the best when it comes to the wound stability with least astigmatism. Induced astigmatism is also influenced by the internal opening of the incision. So we have to make sure that the internal opening is not ragged and it should be uniform. And the paper by Brygensky et al. Has shown that mean induced astigmatism is only 0.6 diopters for a 6 mm incision. And the greatest virtue with the temporal incision is that since it is furthest from the visual axis, any flattening due to the wound is less likely to affect the corneal curvature. And when the incision is located superiorly, both gravity and angular blink can tend to create a drag on the incision. With the rule, astigmatism induced by the temporal incision is also advantageous because in most elderly patients, they have a preoperative against the rule astigmatism. Gokhale et al. Has compared the three incisions, the superior versus supratemporal versus temporal incision, and has found that the least astigmatism is for the supratemporal incision, and then comes the temporal incision. Listing the other factors, nowadays SICS is a sutureless surgery, but in certain difficult cases, sometimes a suture is warranted. And I think we should not shy away from putting a suture, because even the sutures can be manipulated in such a way to induce or to neutralize astigmatism. So with tight sutures, you will get a with the rule astigmatism, and with loose sutures, again you can get an against the rule astigmatism. And always try to avoid excessive cautery because it leads to scleral shrinkage, which leads to astigmatism. And when it comes to hard cataracts, when a longer incision is warranted, it's always better to put a posterior incision in order to reduce the amount of astigmatism. There are several intraoperative techniques available which we can adopt during a cataract surgery in order to reduce astigmatism, like the arcuate incisions, limbal relaxing incision, paired opposite clear corner incisions. So this limbal relaxing incisions, this is one of the simplest one which we all can do. It flattens the meridian in the incised meridian, also produces a coupling effect on the meridian 90 degree away. And this can correct up to 1.5 diopters of astigmatism. Paired opposite clear corner incision, one of the best to deal with astigmatism. The biggest advantage is that the mechanical stability of the cornea is maintained with minimal disturbance to the patient also. There are several nomograms available for determining the length of the incision, and we can correct up to 4 diopters with this type of incisions. Toric IOLs are also nowadays available, which can correct from as low as 0.75 to higher levels of astigmatism also. But it's not suitable for cases with irregular astigmatism or with sonnular instability. The only difficulty with toric IOL is the toric IOL offset or inclination, which can happen, which can induce higher order aberrations that can negatively impact the visual outcomes. Now our senior surgeons are completely evolving the steps of SACS. They are changing the concepts, innovating newer instruments. So they're modifying the astigmatic funnel and changing the configuration of the tunnel also, giving it a Strum's conoid-like effect. So most of the smart SACS techniques are nowadays working like a multifocal IOL. So by modifying the incision site, we can give the patients a multifocal IOL-like effect. So one of these techniques was devised by Dr. Rajiv Raut. He has used a specialized keratoscope with which he puts a SACS incision, which can neutralize the steepness in the upper half of the vertical meridian, but maintaining the steepness in the inferior meridian, which gives a good bifocality. And this he does by visco-stretching the horizontal meridian to maintain the steepness of the vertical meridian. Other techniques are there, like the 2 mm incision by Dr. Amulya Sahu. He has practiced this and is propagating and is teaching this technique, where he has devised newest instruments which can aid in the smaller incision. Because this is a very small incision, just 2 mm, the results are as comparable and better than phacoemulsification, because the patients, the astigmatism can also be dealt with this type of incisions. Other techniques are there, like the manual phaco-fragmentation by Boramani sir and irrigating Victic techniques like Devashi sir. So SACS is continuously evolving, and now it is no more economic surgery or a surgery when it comes to harder types of cataracts only, because now we can use this SACS surgery itself to be give a premium IOL-like effect. So thank you once again. Have an auspicious year ahead.
Thank you, Dr. Raki. That was an excellent talk, and you have shown how SICS is evolving and how our teachers are actually working hard towards making it more and more effective, efficient, as well as, I mean, it has taken care of all the difficulties that we had regarding astigmatism. Thank you so much, Dr. Arti. And last but not the least, we have with us Dr. Aman, who will be sharing his presentation. Dr. Aman, you are ready? Yes, yes, please.
Yeah, a very good morning to everybody. Today I am going to present this video on tackling a hard cataract in colobomatous eye and what happens when things doesn't go as you have planned them. So this was a hard brown cataract with a typical iris coloboma, and I started and thought to do a phaco in this case, and I started with routine phaco steps. And a slightly larger excess. I attempted to make a slightly larger excess than I usually do because it was a hard cataract. And after that, routine phaco steps, hydro was done, the nucleus was oiled, and I started to make a deep and a wide trench. Now, during trenching, I noted that the pupil has started coming down, and the focusing of my microscope was also not very well centered. And now you can see I'm going too much into the periphery, and I'm not able to visualize the tip of the phaco probe, which is a basic in surgeries. I was too much preoccupied in chopping the nucleus because I was not able to break it in two halves, that I forgot that the pupil is coming down, and I'm going too much into the periphery. So finally, with the help of two instruments, I was able to make the first crack. Then I noted that there was slightly resisted movement of the nucleus, but again, I was too much occupied in chopping that I kind of ignored the movements that I was noting in the anterior chamber. So finally, I was able to take the first piece out. And now, if you see here that there is a central PCR, which I probably missed during the case, and I only observed it when I retrospectively saw the video, that it was at this moment that I should have realized that I have done a PCR. So, but again, I continued with the case, and I made a second chop, and I was able to chop the nucleus again. So it was only when after this piece was emulsified and there was space created, I noted that there was a large central PCR, and so with a more than 50% of the nucleus left and a large central PCR, now what to do? I was stuck in the dilemma. So then I decided to convert the case into SICS. I brought the nucleus into the anterior chamber. So a very large incision was not required because the nucleus was already divided into two halves. So a very large incision was not required here. So I started doing SICS. And the nucleus was removed after removing the nucleus. Anterior vitrectomy was done first. It was done around the ports, the tunnel site, and then an anterior vitrectomy with the cortical cleanup was performed. Then we checked for presence of the rexus margin. So we noted that the rexus margin was fine. So cortical cleanup with the IA cut mode was cut IA mode was done, and so a 3-piece IOL was now placed in the sulcus. So as the rexus was large enough, I was able to do a optic capture. If you see here, as the rexus was large, you can see there is ovalization of the rexus margin, which shows that an optic capture has been achieved. So what were the lessons learned? The lessons learned from this case were good visualization and focusing is very important. My microscope was going very decentered at times. My phaco probe was going too much into the periphery, and I was not able to focus properly. Keep your eyes open. Early detection and timely management really saves your day. I should have realized that there is a PCR a lot early than when I realized it. Be careful. One bad stroke can lead to another worse stroke. And the most important lesson is do not panic when going gets hard. Stick to basics. So basics is like SICS is considered to be the basics of all the surgeries. So if you have your hands clear on your basics, then definitely you can progress in all case, and it helps you as a fallback option if things go wrong. Thank you very much.
Thank you so much, Dr. Aman. That was an excellent talk, and actually it is an eye-opener for all the youngsters to see that every one of us are actually basically sticking to the basics only. And if we have our basics clear, we can definitely do a better SICS, and a better SICS is always better than a bad FECO in any day. So thank you so much. So as we come to an end of the installation ceremony of the YO chapter of ISMSCIS, I thank all of you for joining us here. And I would like to request Sahu sir to say something before we close. And also Dr. Boramani sir.
Yeah, Karan. Karan, your video shows your experience, and we are very happy that you are there. And one target I want to give you: spot the best talents available in all over India and bring them to this fold. And one thing is that they should be positive and apolitical and not egoistic people. We can't tolerate egoism. We can't tolerate negativity. We don't want anybody coming and showing off their nonsense, and there is no time to waste. So please focus on the positive people, nice people. Let us enjoy them. And Raki, I will request you whether tell you spend some at least 6 months course with Nilutpanda and pick up the finer points and the 2 millimeter from there. And if possible, I will also request Jagannath to start his teaching his own modulations, astigmatism. We have been always looking to the West for guidance. Now we have masters like Boramani, MS Ravindra. They are doing excellent work, and all of you who are interested, young people, spend some time with them and pick up virtually also their techniques, and so that you can become the world who will look up to you to give them guidance. We need the whole people of next generation, the leaders. That is the purpose of this platform. We want to create you leaders, not followers. So, but you have to learn, go through the process. And last but not least, Aman also showed a very wonderful thing, and he was honest enough to say what problems we can face and how to solve it. I'm very hopeful. This is a very bright people are here, and our future is good in this ISMSCIS. We are going to lead the world. With this, I want to rest myself. And thank, of course, the vote of thanks will be given by Nilutpana or whosoever city delegates. But I am very happy. I am very positive about this thing. Well conducted, Nilutpana. Okay.
Thank you so much, sir. Dr. Raki, it would be a wonderful opportunity for me to have you with us at Sri Shankaradeva Netralaya. We look forward to our collaboration. And now I would like to request Dr. Jagannath Boramani, sir, to kindly say something.
Yeah, I congratulate all the youngsters for their excellent talks. All the talks were excellent. Somehow I missed Dr. Manik's talk. I'll just watch it on YouTube because someone had come in my house. But all the talks were excellent. Dr. Karan's videos were fantastic. SICS, the merit of phacoemulsion over SICS is always stated that it is a small incision, hence the induced astigmatism is minimal. But this can be achieved with SICS also by either a 2 or 3 millimeter incision. SICS is possible with a very small incision. But the beauty of SICS is that we can take the SICS to a higher level, because now it has been proved that if you want to induce, you induce astigmatism. But yes, SICS, even with a large incision, like Dr. Ravindra also does with a large incision, but induced astigmatism is minimal. So there is a technique of modifying the wound. So when you want to induce, you induce the astigmatism. Instead of induction, I'll use the word neutralization. If you want to neutralize, you neutralize the pre-existing astigmatism. But if there is no pre-existing astigmatism, you don't induce anything. So this flexibility is there, and that is the greatest advantage of SICS, which is not possible with phaco. With the standard incision, corneal incision, there is a sort of standard induced astigmatism. Plus, the flexibility is very less in phaco. If the probe becomes little hot, then the results are very unpredictable. The results are quite predictable in scleral incisions. So with wound modifications, you can play with the astigmatism. And if you learn this thing, the SICS becomes an advanced technique. Then it may score over the frequent emulsification. Even the endothelial loss is less. Many of the major institutes also we have seen a standard procedure is performed because of the workload and this thing, and no much attention is given to this improvements in the SICS. They just do a standard patapat within 2 minutes. They have to finish. Lot of workload is there. So if you learn advanced SICS, you can always promote as a premium surgery. There are surgeons in India charging almost. Dr. Raki has mentioned about Dr. Rajiv Rao. He is charging 2 lakhs for SICS. That is his package, and people are paying for him. He has got a big list waiting. So, and she has talked about the Dr. Gokte's meta-analysis, wherein the happiness with near vision is more in SICS, but this happiness is with mainly illiterate people, wherein this range of vision, the range of focus they get only because of the astigmatism. So it is an astigmatism induced, but this astigmatism induced range comes at a cost, and that cost is the little poor quality of the vision. Somehow the illiterate people are happy, they don't want to read. So they always say near also is very good, distance also is very good. But if we can give a good control on astigmatism, try to neutralize astigmatism, then you can use premium lenses, multifocal lenses, or maybe now in India we are having autofocus lenses. This is not an extended depth of focus, but this is a lens which gives good distance, near, intermediate, everything, but without any rings. So the rings, halos, glares are not there. It's a new lens designed by Indian surgeons, available only in India. So it's something like a progressive glass. In intraocular lenses, progressive lenses were not available, but this is the first progressive intraocular lens available in India, and soon it will be available to everyone. So this gives a very good multifocal effect. It's not like an extended depth of focus, and it's like a multifocal lens, but without the disadvantage of glare and halos. Dr. Raki has also talked about the smart SICS. This is another fantastic technique wherein Rajiv Raut is evolving this technique. Even I have done cases with smart SICS. She has talked about the manual keratoscope. I got very good results in some cases with the manual keratoscope, but now it is a LED keratoscope, the LED ring which is attached to the microscope. And now it is a software guided. The software guides us regarding the incision. So it is giving more advantages. I also done many cases before the pandemic, and now very soon it will be a robo assisted. Dr. Rajiv Raut is working on it. It will be ready within 1 month, and mostly in our Chandigarh conference there will be live demo of robo assisted smart SICS. But still, as on today, it doesn't give 100% result for 100% of the cases, but at least more than 90% patients are satisfied. With the monofocal, they get a very good multifocal effect. So this technique also is a fantastic technique evolving. So I request everyone to learn all these advanced techniques of SICS. So once you learn SICS, then like Dr. Ravindra always says, if patients gives you a choice, will you do PEC or SICS? You'll always do SICS. Thank you very much.
Thank you, sir. That was absolutely enlightening, and I hope that the youngsters will definitely look forward to this. With this, as we come to an end of the session, it is my honor and privilege actually to be a part of this chapter. On behalf of the youngsters, I would like to extend my heartfelt gratitude to the esteemed office bearers of this wonderful initiative to install the young ophthalmologist, that is the YO chapter of ISMSICS. We are indeed privileged to take forward your vision. Dr. Sahu sir and Dr. Boramani sir, we look up to you. I sincerely thank the esteemed members of the advisory board for sharing their experience and always encouraging us to take forward this vision of SICS. Sincere gratitude to the mentors for their efforts towards this initiative. We look forward to working together with the Young Brigade, which is headed by Dr. Karan, Dr. Nandini, and Dr. Raki. Congratulations to all the office bearers, to the executive members and the scientific committee. Last but not the least, I would also like to thank the technical partners for this meeting and Todd Pharmaceuticals. And with that, we come to an end of this session. We look forward to a great year ahead, and we look forward to the Yo Pavilion presence at the World Conference of ISMSCS at Chandigarh in March. And have a great year ahead. Bye-bye.
Thank you. Thank you so much, Dr. Nirupana.
Thank you, everyone.
Thank you so much.
Thank you, everybody. Thank you.